Christine, we can start the session now. Please add your email address as you're introducing yourself in case you want us to reach out to you after.
Good afternoon, everyone. Good evening. Perhaps there could be someone who has just started their day. Good morning. Welcome, all of you, to this forum where we're going to be having a discussion, a media roundtable on the Lancet reports that the Lancet Commission for Ending Stigma and Discrimination in Mental Health has prepared for us. And today we are very privileged. We have 3 speakers who are going to be taking us through this session. Right now, I would want to just share with you, as I'm hoping that you can all see the slides. Allow me to introduce myself, and then I can share with you what we're going to go through and what the objectives of this are. My name is Christine Ngoku. I am a journalist, though not practicing in a media house currently. I am working at the Media Council of Kenya, so I am Kenyan, a Kenyan journalist with 25 years of experience, and I have had opportunity to cover mental health, albeit more than 15 years ago. My most recent interaction with mental health is developing a curriculum or guidelines for mental health coverage for use by journalists. But at the same time, I have also had a few interactions with lived experience of people who have mental health issues in my country. For the media roundtables, this is the second time I'm facilitating this media roundtable. And so I am a bit familiar with the content that comes out of the Lancet Commission. And so I want to just welcome all of you. Keep your questions, write them down so you don't forget them, or comments or observations as the discussions go, as the presentations go. And at the end, when we get to the plenary session, then you can voice them. You could raise your hand. At the moment, I would want most of you to do your registration, put in your name, put your media house, put an email address. It would be nice also if we know which country you're joining us from. That would really, really be lovely. So for today's media roundtable, we have the objectives as facilitating open and honest conversations about the role of the media in fighting mental health related stigma and discrimination. There has been quite a bit of stigma, sometimes intended, sometimes unintended, because of how the media reports on mental health. We also want to track the progress on the implementation of the Lancet Commission on ending stigma and discrimination in mental health, giving journalists an opportunity to reflect, respond, and take action. In our session of sharing, I think we're going to hear from some journalists who have had exposure to some of the proposals that have come from the Lancet Commission on how journalists can cover mental health to reduce stigma or even end stigma. There will be a presentation from a journalist. Our third objective is to ensure that the media outlets are provided with sources of accurate information they need in order to report mental health issues in a responsive and sensitive manner. When journalists report on mental health, it's a sort of special kind of mental a health issue. And so there's extra sensitivity that goes with how mental health is covered. When we write about people who have issues with mental health, it's very important for us to be a little more sensitive. So for this particular roundtable, in the next 50 or so minutes, we are going to be discussing some of the strategies, probably approaches that we can use in order to be sensitive when we report on mental health. If anyone has a question, you can post on the chat, or you have an issue, maybe you're not able to hear, you can just post it on the chat. My colleagues who are online are going to help to catch some of those issues, and we will be able to respond so that you can participate fully. On the panel today, we have two commissioners who will be sharing recommendations of the Lancet report and progress to date. We have Graham Thornycroft, we have Charlene Sankel, and then we also have someone who will be sharing best practices on reporting on suicide, Mark van Omrod. I'm not sure I can pronounce that name very well. I have a list, and so forgive me, Mark, when I make those mistakes. Then we also have a contributor, Joshua Duncan, a lived experience on mental health coalition from Sierra Leone, from the Mental Health Coalition. And then we will have a pair of journalists who will also share their experiences on reporting positively on mental health in Africa. We have Katie Katopodis from Nala Media in South Africa. She is a prominent South African journalist and will be speaking to us on how she reports mental health. And we have Bridget Ghana from Nation Media. She works in Kenya and has attended various RT and wants to share how she has implemented the recommendations of the Commission in her stories. So without much ado, I want to take us really quick to start off our discussion for today. And we will start off with Professor Graham. He is a professor of community psychiatry at the Center for Global Mental Health and the Center for Implementation Science, Institute of Psychiatry, Psychology and Neuroscience at King's College London. He is also a consultant psychiatrist at the South London and Maudsley National Health Service Foundation Trust. He's working in a community mental health team in Lambeth. He is a fellow of the Academy of the Medical Sciences. He's a National Institute of Health Research Senior Investigator Emeritus and an honorary fellow of King's College London and the Royal College of Psychiatrists. Graham took his undergrad at Cambridge in social and political sciences. He studied medicine at Guy's Hospital, London, and trained in psychiatry at the Maudsley and Johns Hopkins hospitals. He gained a Master of Science in Epidemiology at the London School of Hygiene and Tropical Medicine, and a PhD at the University of London. He has made significant...
Maybe too much, Christine.
I beg your pardon. Let me just do this last one, because okay. I think it's really, really good. He's also very active in global mental health. For example, he chaired the World Health Organization Guideline Development Group for the Mental Health Gap Action Intervention Guide, first, second, and third editions, a practical support for primary care staff to treat people with mental health. Now, looking at this wealth of experience coming to speak to us, I think I feel that we are really privileged to hear him first, because then he can now give us a broad perspective and then bring it all the way down to the perception of mental health today and the report of the Lancet Commission in terms of how mental health is perceived. So, Professor Graham, the floor is yours.
Christine, thank you.
I don't know who it is that has a cold. Is it you? Are you the one sneezing? No. Okay.
Not yet.
Not to worry. There's
Okay.
someone whose microphone was on and they kept on sneezing, so I was worried that it was you.
Christine, thank you very much for that kind introduction. Please just let me know if you can see my first slide on full screen.
Yes, we can. Yes, we can.
Great. Okay, so greetings, everybody. And thank you very much for inviting me to contribute. I want to say a little bit about how to stop stigma and discrimination. So first of all, what do I mean when I talk about stigma? Well, This is one way of understanding it. Bernard says, I had a relapse at the prayer camp and I was tied like a sheep. They tied my legs together like a pig or an animal at a butcher to be carried home. So it means quite often people with mental health conditions being treated without respect, or even worse, or much worse. It means a series of violations of the human rights of many people with mental health conditions, toxic effects across the world, leading to marginalization, social exclusion, poor access to mental health care and poor access to physical health care, and reductions in expectations of family life, education, employment across the board. One way of thinking about stigma is that there are 4 types: internalized or self-stigma, stigma affecting people near to the person with the condition, family members, for example, public stigma incoming from the public towards people with conditions, and structural or systemic stigma. For example, so little is spent by essentially virtually every country in the world, the governments, upon mental health. So I'm going to refer to some illustrations, particularly from this toolkit from a group called Time to Change Global. Who does it affect? All of us, people who sometimes among our very many characteristics have experience of mental ill health. People in countries like Ghana, like Nigeria, like Uganda, like Kenya. So I'm going to take it as given for this part of my talk that stigma is a bad thing. Do we know about what to do? Do we actually have information about how to reduce stigma? Well, yes, we do. Along with my colleague Charlene Zunkel, the head of the Global Mental Health Peer Network, we led over the last 2 or 3 years a large collaboration to produce this Lancet Commission report with many colleagues across many parts of the world. One part of this, which Charlene led, is a survey of about 400 people from over 40 countries around the world in several different languages, most coming not from rich countries. Nearly everybody said that most people with mental health problems are negatively affected by stigma. Interestingly, the large majority said that stigma and discrimination can be worse impact of the condition itself, and that the media, today's topic, can make stigma and discrimination worse. So I'd like you to remember only 2 words from my 6 minutes talk today. And those words are social contact. So we've looked at all the evidence across the world on how to reduce stigma. We found over 200 review papers. And social contact is what works. What does this mean? It means making arrangements for ways to bring together people who do have experience, lived experience of mental health conditions, and other people who do not. So Edwin in Kenya says, when I keep quiet, stigma wins. I can't let that happen. Godfrey in Uganda says, people with lived experience of mental health are essential when it comes to challenging stigma. Sandra in Kenya says, speaking up about mental health is the surest way to end stigma and create more safe spaces. It means talking openly. It means featuring stories, positive stories in the media, stories that you need for your copy, for your returns, stories of people's challenges and their support and their recovery and their positive hope for a better life. So Martha began to have mental health condition when she was at school, and now is a champion in Ghana, actively promoting mental health. How do we talk about this? Often it'll be in person, but social contact can also be by digital, remote, social media, online methods. But there are risks of reputational damage for people who speak openly, when we have to use other methods, for example, dramatizations with actors playing the parts of people with mental health conditions. The actors themselves may have experience of mental ill health, but may choose to disclose or not to disclose that. There's a little bit of background noise. It means people speaking in their own voice, in the first person about their experience, people speaking in groups, support groups, advocacy groups, self-help groups, peer groups. It means putting together advocacy and public understanding campaigns. For example, it could be you in Nigeria. For example, Speak Up in Kenya. So to summarize, I'd like you to only remember 2 words, which are social contact. And that means that the role of the media should be the positive one. For example, good practice in reporting suicide, not reinforcing stereotypes such as unpredictable or dangerous. Not using derogatory terms which are common worldwide, you can see a few examples here, but using a positive approach such as the person first, a person with mental health condition, a person with lived experience of depression, and so on. Now, our Commission report makes 2 recommendations in relation to the media. That national and international media organizations should be called upon to issue policy statements with respect to mental health and action plans on how they will actively contribute towards reduction of stigma and discrimination. So this is my message for today, to remember, social contact is what works for stigma reduction. If you'd like further information, I'll be very happy to send you chapter and verse. Please do contact me if you'd like. Thank you very much for your attention.
Thank you, Professor. That was really nice, brief and to the point. And I like the way you put it in bullet points, because then we're able to capture, the message. It's easy to remember the presentation really easily. I like that you said that we need to just remember a few words, not a whole sentence. Social contact, and that for me is a good. So I'm really excited to introduce the next speaker. Our next speaker is Mark. Hold on just a minute. I think I've lost my screen. Our next speaker is Mark. I will not try to say your second name, Mark, and please forgive me, because I think it's a German name, and I could get my tongue twisted in my mouth if I try to say it. So Mark is head of the mental health unit of the World Health Organization, Department of Mental Health and Substance Use. The unit covers suicide prevention, amongst many other topics. Recently, he coordinated the writing of the World Health Organization 2022 World Mental Health Report, titled Transforming Mental Health for All. Much of Mark's earlier work has focused on initiating and developing widely used policies and tools on mental health in humanitarian settings. Mark, you're ready to join us and you can take the floor. I'm not sure if you have a presentation, and if you do, go ahead and present it. Mark?
Thank you. Thank you, Christine. I do not have a PowerPoint. I will be speaking.
Okay.
And I am delighted to be here, and I'm delighted the opportunity to speak to media professionals, which is not something I do very often, other than in the interview, and this is very different. So
Yes.
So I like this. Thank you. So in suicide prevention, there's a number of strategies. In WHO, we highlight 4 of them, and one of the 4 is working with media professionals. So actually, you are a part of our strategy to reduce suicide around the world. And there's 2 aspects of that strategy that I'd like to highlight. One of them relates to stigma, and the other one relates to avoiding copycat suicides. And you can help with both issues a lot. So, in fact, we have been having a resource for media professionals for many years, and we're updating it this year. There will be, and thanks to United for Global Mental Health for helping us get peer review from media professionals, maybe from you if you're here, thank you. And it will come out later this year, but if you send me an email, I can get you an advanced copy, not for dissemination, but just for your use and interest. So what does it say? It will basically, in terms of stigma, it will highlight a number of language choices that you can make. Some of them very simple. You know, in the past, there was many countries in the world where suicide was illegal, including my own country. And now these days, it's still around 20 countries. The professional consensus is that this is a mistake, that suicide should not be illegal, because if it's illegal, people cannot talk about it, cannot seek help, and it stigmatizes. So but in our language, how often do we say commit suicide? Use that language. Commit is a legal term. Commit a crime. So we encourage you not to use the word commit suicide. You know, kill themselves. Kill themselves means kill. Again, a legal term. Killing is illegal. So those are the one better used: died by suicide or suicide attempt. But also there's other terms, like we often in the news you read about political suicide or suicide epidemic. And you often see the term successful or unsuccessful suicide. This is a language I used to not notice, but now I notice. Successful suicide means that it's something successful to be achieved. And we have an issue that in mental health, most mental health problems are not contagious. Really, they're not, even though people sometimes may worry about that, and if one is naive. But there is some form of social contagion around suicide. So we have to be really careful how we discuss it. So here are some tips for reporting on it. First of all, when reporting on suicide, provide accurate information about where to seek help if one has suicidal thoughts or plans for acting on those thoughts. Of course, as the media, you are essential for sharing the facts about suicide and preventing suicide. Suicide is very common, 700,000 people a year. Access to easy means like highly hazardous pesticides in many countries or guns increase the likelihood that people in society will attempt suicide. But also positive stories about how people cope with the feelings and thoughts around suicide, which are very common. And there's evidence that positive stories around suicide actually reduce suicidality in the population. The most important thing is to be extremely careful in reporting celebrity suicides. This is where things really go wrong often. So when celebrity suicides are reported without a lot of thoughtfulness, there is a high likelihood of copycat suicides. And this is there's a lot of data on that. So what does that mean? Does it mean you cannot discuss the topic anymore? Yes, we can, but there's ways of doing it. First of all, do not describe the method used. That's the most important thing. So a better article does not mention how the person died, because again, the contagion element is just enormous around show. Don't just provide details about where the site and location, in case there's a story around jumping. Then there is don't put it in the headline suicide, again, for the contagion. Don't report the details of a suicide note. Certainly don't use photographs, video footage, audio recordings. Don't sensationalize. So those are all there's many tips like this that are extremely important, how you can help in reporting, in reducing suicide. And with that, how you report, you will be able to reduce the stigma around suicide by giving facts and by not using language that stigmatizes. Christine, I think my time might be up.
Thank you, Mark. Yes, it is. That's why I sent you a message.
Thank you.
But thank you very much, Mark. And I think you've, hit the nail on the head, as we say in Africa, because you have actually talked about some of the 5 W's and H that journalists use. Where did it happen? Who did it? What was it? And so on and so forth. And now you're telling us we need to review how we look at stories when we do stories around suicide. Thank you very much for your thoughts. We now want to move to our next speaker. Joshua has just joined us. Joshua, you don't have very much time because we're just getting to your session. I will invite you to introduce yourself, Joshua, and take the next 6 minutes. Joshua, are you here?
Yes,
Joshua,
yes,
yeah.
I am. Thank you. It's a great opportunity bringing out discussions around stigma, discrimination, and issues bordering suicide. It's a passion, and I would rather bring key issues from an experiential point of view. Joshua Abiose Duncan is my name, the country director for Mental Health Coalition, and the country focal point for the Speak Your Mind campaign for the United for Global Mental Health and advocacy, someone who raises awareness and at the same time, capacity builder. Allow me to speak from this point from the perspective of a user, so we would be able to fully understand that in as much as the concept is great, the experience resonates the need in a clearer way. I was age 4 when I started school, and honestly, I was excited for my first day in school, only to realize that when I went to school, I suffered from an emotional abuse and stigmatization because I had sores in my body, not one I created by myself, but one that came because our country was having a poor health system. I was retaliative, and after that incident, I couldn't go to class because I retaliated in a physical way and was really afraid that my teacher will come hard on me. And that is basically because in the context where I grew up, the victim is double victimized and the perpetrator justified. And for me, I thought that damaged my resilience and emotion and self-worth for ages. And so you would realize that even when I was coming up, I struggled. I had a self-stigma. My health issues continued to linger in my mind, even though my health was restored. There was also another situation when we had the rebel crisis in our country, and I was moving from point A to point B. Again, rashes on my body because during the rebel war, there was literally little access to health services, and those that are available are very private, costly. I do not come from a rich home, so you would realize my parents couldn't afford. And on the public transport, let me call it public bus, moving from the east to the west of town, there came the soldier and says, this boy, based on his skin layout, resembles a rebel and should be taken care of. In our context, when such statements are made, means you do not go to the court for justice. Justice is meted on you by the people, and it's really not a crime. So the people in the public bus said, if he is a rebel, you are a soldier, you are carrying a gun, you know exactly what to do. Come down and do it quickly, which basically means get rid of him. I mean, shoot him on spot and just kill him. I protested, but it was a faint one. I was already emotionally paralyzed. And very few people could even pay attention to my plea that I am a gentle young man who is moving from this point to this point. Then I realized social stigma or stigma by the community is one that judges you even faster than the High Court judge. That damaged me as well. I would also talk about the thought, then I would bring my points clear. We were young. My grandmother sent me to buy some cups of rice. And because during those times, eating rice was a luxury for us. The country was really at low level in terms of economic survival. Happy I was running down the lane to buy those packets, 4 or 5 kilograms of rice. And on the way, I misplaced the money. I couldn't go back home. We were only residing with our grandmother because our father couldn't afford for us. And for us in Africa, that is double shame when a husband cannot take care of the family and revert to the maternal grandparents to step in. I remember my thoughts around suicide. That is why I resonate with the idea that we wouldn't say commit suicide. It's not a crime. Rather, an individual may die by suicide because of certain factors that militates against them. And so I realize our idea around stigma and discrimination as a wrong perception. It is being viewed by the people who see you and who determine what your future is, of who feels, which we'll call societal perception, who feels you are what you are based on their own imagination and could not afford to look through your eyes, through the lens, maybe behind the smiling face, in the shadows, those challenges you face. And so all throughout my experience, until in recent past, suicidal thought has been key because of the huge stigma and discrimination I experience, both as an individual, as community, at institutional level. And this is quite a challenge. Thank you.
Thank you very much, Joshua, and thank you for your honest sharing and for coming in immediately and just joining in the conversation. Thank you so much for, sharing very sincerely how early, at what early age that you started experiencing this kind of issues that now, propelled you into mental health issues. Thank you very much. I want to bring in our next speaker. And our next speaker is from South Africa, Joan van Dyk. And probably Joan is going to tell us about how the media shames the narrative around mental health. This is really a big one for the journalists in the room, and even for journalists who may not necessarily be here. The question of how journalists frame the narrative around mental health is a really, really big question. Faith, is Joanne here? Unless she's logged in a different name. Okay, Joanne, the floor is yours. Oh, there you are. I wasn't seeing your name anymore. Thank you. All right, go ahead. You have 6 minutes. Try and keep to the 6 minutes so that we can have a good session of plenary.
Thank you so much for having me. I'm Joan. I'm the news editor at the Bekisisa Center for Health Journalism in Johannesburg. And I wanted to speak to you about a story in South Africa that I think encompassed a lot of the issues that are being discussed here today, and that is of the Life Esidimeni tragedy, where under the auspices of deinstitutionalization, a bunch of mental health care users were moved to nonprofits that weren't equipped. And at least 144 people died, but that's just that's just what we know for sure. It was an incredibly traumatizing story for everyone involved. The media exposed the way that these patients were being treated. There were seriously harrowing details of their how they were abused basically and treated, you know, put onto trucks like, you know, they were cattle and shipped around with absolutely no regard for their human rights. And so because it was the media that uncovered this, I think the aspect of advocating for patients was there, but still there were some mistakes that slipped through that I think we can reflect on if something, hopefully this never happens again, but for future stories like this. Because even though it was, you know, we were advocating as the press for the patient, and like no one deserves this, especially people who maybe these were severely ill people and people who couldn't necessarily advocate for themselves. And so on the patient level, we were doing fine. But I think one of the narratives that came out of that is the portrayal of the family members who had been looking for their ill siblings or children or whatever for months, ended up being portrayed as being completely careless. And, you know, you just decided this person was unwell and put them in an institution and forgot about them, when that was not the case at all. These people had been fighting for so long to get information about their loved ones. The other problem is that what ended up happening is that deinstitutionalization ended up being framed as a fundamentally bad quality, even though it's, you know, part of a global push and an evidence-based way to both say, cut down on costs and also just have like a more human rights-based mental health system. So instead of framing this as a policy that was rolled out badly, it was just described as a bad policy that we should avoid. And so as a result, after this, there was a big arbitration, incredibly emotional one as well, about this tragedy. South Africa's mental health plans to deinstitutionalize haven't really gone forward, which is the opposite of what should have happened to improve the mental health care even more. So I would love to hear everyone else's thoughts, or any of the other reporters in the room, what you think about that. And then also I wanted to just mention everyone's aware of the pressure that the media is under, and even in a situation that I'm in where we have a lot more time to look at things and to work on a story for, say, 2 weeks instead of having to push one out every day. We have, because we're online, we have seemingly endless space to write, but we have limited attention span. So I think to catch your reader, you've got like 20 seconds before the reader clicks away. So I think that also what that means is people end up leaning into the cinematic element of a situation, even if they, in the rest of the article, are being very measured about the things that they're describing and trying not to stigmatize, but just the fact that there's the attention economy that we have to pay attention to, the strange behaviors of someone who's very ill is then like a very easy way to keep someone's attention. So that's something I think we can all think about, and we need kind of to think about a different way about doing that. And my last comment is just about giving people good information. And we've realized with reporting on stigmatized health services, whether it's abortion or transgender healthcare, all that kind of stuff, the best way to get people to really stand into the rights that they have in the law and their human rights is to give them good information. And that's something I think we can learn from the HIV advocates, to give people information about what they can expect, what should they look out for, how to spot like dodgy things online, how to protect yourself. Those things we found the very instructive public education explainer pieces to be very powerful for these stigmatized topics. If I can just squeeze in a last comment, I think we need to think about these words that we want to avoid, but also in the local languages that we're all reporting on. Because in English, there's definitely a list that we're aware of, but we need the patient advocates and the civil society to help guide us away from words in the languages that we're all writing in on the continent. Thank you.
Thank you very much, Joanne. I can see you were struggling to squeeze in everything that you wanted to share with us, but see, we want to have a plenary, which I see its time is really, really gone. Perhaps there's a request, and I think I want to put that request now. Could I request everybody on this forum for 10 extra minutes, just so that we can have some time to discuss the issues that have been raised? I would want to just, put a reaction and just put your hand up from the reactions if you're in agreement for an extra 10 minutes. While we do that, I want to introduce our next speaker, who is a Kenyan like me, Bridget Ngana. She's a journalist in Kenya, and she attended previous roundtables, and she will share how she has implemented the recommendations of the commission in her work. Just one last thing about Bridget Ngana, where recently the Media Council of Kenya had the National Journalist Excellence Awards, and she was among the finalists. So a big thumbs up to you, Bridget. Go ahead, Bridget, and make it really, really quick. Okay, we see your presentation is coming, but we're seeing the bottom of it. Thumbs up, guys, if you want us to do, if you can afford us an extra 10 minutes.
Yeah.
Thank you.
Can you see the presentation?
All right, Bridget, get going. Bridget. Bridget's Ghana. Bridget, did we lose you? I'm not sure what happened to Bridget, but her presentation is up.
Yeah, it looks like Bridget's dropped off. I can't see her.
Okay, maybe she dropped off.
Oh, you're back. There, Bridget.
Okay, it's your slot, Bridget.
Okay, thank you so much for that wonderful introduction. I don't know why the internet decided to fail me right now, but thank you so much for the introduction, Christine, and everyone else who's on this set. So just to go straight ahead into this presentation, I wanted to share my screen, but I see that you've already started sharing. So ideally, if I can just maybe start talking, because I know we're really pressed on time.
Just keep going.
Yes. So the basic importance maybe of me being part of this is at least I'm getting to learn more about mental health reporting and all that. And so the media, as the representative from WHO said, we are propagators of stigma and discrimination. And this maybe we are doing it not willingly, but maybe the lapses that are in newsrooms currently. And I'm glad that they've mentioned that there's that glorification of how somebody died. If it is a case of suicide, the way some reporters, myself included, have gone on maybe to describe. And these are some of the things that are not helping in terms of ending stigma. In the 20 countries, I think Kenya is still one of the countries in the world that still continue to propagate or suicide is a crime, and the Kenya Psychiatric Association has been on record trying to decriminalize or to push for a change in that law here in the country. There's also the issue of us journalists emerging mental health stereotypes, and also this has been highlighted by the commissioner who's from the WHO, and this is also a taboo topic because people really do not talk about mental illnesses publicly. It's perceived here locally in rural Kenya as something as a curse, evil, spirit, possession kind of thing, and because mental health is invisible, then it's also another thing. Trying to fight for it to be featured in the news is usually hard. The journalists here in this section will tell you, when you start talking about mental health stories, the editor looks at you like you're like from Mars and it's not sexy enough. So this is also a case in point where the story that won the award in the mental health and wellness category in last year's Media Council Awards in 2022, we really fought to have an editor to listen to us and kind of give us the go ahead to go and work on this story. And this was a story I had started seeing because in weeks on end that followed each other successively. I had a story of an underage child who had died by suicide in one location. And I felt like we need to change how we are covering this story. And we did go and spoke at length with the families of the affected families and also mental health experts here in Nakuru who helped us move the story forward and create awareness on how important mental health is. This was coming in the wake of COVID-19 pandemic and schools had been shut for 9 months. So children were also trying to process their own way of navigating the pandemic as much as Kenyans, rather adults, were also going through that. We can also have this journalists who also, when we are being trained, we are told that we are outside the story, we are not part of the story. But the thing is, when you're covering a story, you are affected, whether you can sense it or not. Over time, it builds up, and this is now bringing us to a scenario where Christine was mentioning that now more journalists are becoming vocal, and we have journalists who have even gone public on how they have had experiences with their mental health conditions, and it's really an ongoing conversation in newsrooms. But right now, also the biggest story here in Kenya is the Shakahola massacre. And for more than 3 weeks, we've had journalists going to a location in coastal Kenya where there's a pastor who has brainwashed faithful to fast and die, and that's the way they're going to meet Jesus. So these are journalists seeing the exhumation of these bodies, and there's that trauma. Just even here in Nakuru, we are on the Great North Road that links Kenya to the rest of East and Central Africa, and we do cover a lot of accidents, especially during peak travel seasons, during the festive seasons, and even being there for the first time, seeing blood and all that. These are traumatic experiences, and as journalists, I think it's time we started also accepting the fact that we are affected, and there's a lot of post-traumatic stress disorder in newsrooms, and we need to have mental health support for reporters like myself, but that is not happening. So going on to coming across the Lancet report on stigma and discrimination and the United Global Mental Health Bending the Curve report that was came out last year towards the end of the year, ahead of the World AIDS Day celebrations, I've really improved in terms of how I cover these stories. And one of the things that I really saw as important in the Lancet report is having people with lived experience sharing their stories. This really humanizes the whole aspect of mental illness. And it is also a safer way, because when somebody tells their story, then people can relate directly instead of me saying it as a second person or experiencing it from a point of view of another person. So these people are very, very powerful and key. And there are stories I have done where I have spoken with people directly affected, especially in the case of HIV and AIDS and TB. And it has really helped in adding value to the story that I do. And numbers don't lie. When you look at the United for Global Mental Health report on Bending the Curve, they say that if mental health is integrated in how TB and malaria are treated, and these are one of the key big diseases here in Africa that are still a public health challenge. You see that if we do integrate mental health, that report cites that they could be a prevention of nearly 1 million HIV new infections, and maybe even reduce TB infections or avoid TB infections to the tune of 14 million people or not being affected, and that is by 2026. So it's really important for us to continue to create awareness.
Your last 2 points.
Oh, my last 2 points.
Yes.
Oh
please.
my goodness. Okay,
Yes,
so
gone.
so thank you so much. In my last 2 points, I think the media needs to continue creating awareness on prioritizing mental health in healthcare. We have the Mental Health Act here in Kenya that was proposed by Senator Sylvia Kasanga, and this is a step forward because it means now there'll be the integration of mental health councils in the county governments, and also there is the Mental Health Task Force of 2020 that was commissioned by former President Uhuru Kenyatta that sought or recommended that mental health be declared a national disaster here in the country, and that way it could get the same attention that other diseases like HIV and AIDS have gotten, and also like priority diseases like malaria and TB. So thank you so much. I have a link of the stories that I've been able to cover in line with the recommendations of the Lancet report and the United for Global Mental Health report also. I will share them in the chat so that you can go and have a look, and also the award-winning stories. But this is an ongoing conversation, and I think I will be looking at even the report from the WHO about mental health coverage in terms of improving how we do stories on mental health and wellness. And thank you so much. Christine, I think I'm done.
Thank you. Thank you, Bridget.
That was fast.
Thank you. Yes, 6 minutes goes really, really fast.
Oh my God, yeah, really.
So I want to just thank all our presenters today, the team from the commission, from the Lancet Commission. I want to thank also the lived experience that I've shared. I want to thank you, Bridget, for bringing in the journalism in practice perspective to this. I have a surprise for Professor. You know, one of the faces that he showed was actually my student when he was showing just examples of, you know, people in this space of mental illness and mental health. Her name is Charlene, and Charlene is one of the people that we worked closely with. Having graduated with a journalism degree where she was my student, I now meet her again, and we are busy developing the guidelines for journalists on reporting on mental health. So I can see it's a big world, and then it's a really small world that the professor was able to get a hold of her as well. So I want to see people raise their hands. Maybe if there's anyone who has put a question on the chat, we will read it out. Let me have a look at the chat. Faith, you could also help me look at the chat so that we don't miss anybody's question, comments, observations. But I think this has been a really, really informative exchange between the experts and the journalists and the lived experience. If you were to ask me, it's one of the big, nice approaches that we have, where we bring in the scientists, the team that comes up with the reports, and even medical research, the writers, which is us, the storytellers, the journalists, and then the subjects of the story, the people who we write about. It's good when we get to hear how they see the perspective that we write about them from, and it's really helpful for us to hear. Especially, I was really touched by Joshua's story when he says that the public judges you and actually passes judgment, so to speak. And that for me is really good, because the journalists can also come from the same perspective and decide they are also condemning, judging, you know, and giving that kind of approach in the story that they are writing. There's someone who has written a comment. Faith, you have your hand up. You want to read one of the comments?
Just pointing to Andrew's comment, and
Yes.
just so that he can share by himself. Yeah.
Yeah,
Question.
Sure. Go ahead. Andrew?
Oh yeah, this is Andrew. Thank you so much to all the presenters.
Thank you,
Bridget, thank you so much. I know how hard it is in the newsroom to pitch for mental health, but my question is, how best can we report suicide that we don't ignite copycats, but at the same time find appropriate language? Because given that we're coming from the different walks of life, suicide is a taboo. It's close to a curse in our communities where we come from. So how best can we report suicide and it's not misunderstood? That's one. Then secondly, to those of you in the different countries who have used some models on the languaging, do you mind sharing some of those models on the languaging that can make it easier? Then two, do we have any support for anyone who is focusing a lot on suicide prevention? Because we are reporting a lot about the suicide, we're reporting a lot about the causes, the pain points, but we're not reporting about the first aid, the suicide first aid, and the suicide prevention models. That's where my interest is. Thank you.
Thank you, Andrew. Thank you, Noella. Noella Luca is one of the participants, and she says that, hi, Christine, I'm a former journalist and made a film on mental health in collaboration with BBC Africa, touching on various aspects, including stigma. I think that she has given us a link to that story. I think it would be a good idea for people to just go to that and pick it up. I think from the presentations that were done, if I remember well, Mark was talking about the language choices that we make. You know, when we say commit suicide, the word commit already implies the legal aspect, and it makes it, if you like, an offense. Kill, you know, killed themselves. You know, that also has that implication of breaking the law. And so we need to, he was suggesting that we need to make better choices in terms of the language that we use to refer to it. We need to also, you know, talk about mental health, not from the point of, oh, it was an unsuccessful, because then people think, oh, then I need to do it successfully, you know, so it's some of that. I think at the beginning also we had a presentation, on the presentation there was somewhere about discriminatory language and discriminatory or derogatory terms, which then make it negative, that demean the human dignity of this person who has a mental health issue. I think as a journalist, once you've done your story, you want to go back and read it again and ask yourself, have I portrayed this individual or the subject of my story in the most positive as I could? Assume that this was someone who had excelled in exams. How do you write about that person? Do you write about them in the same way? You know, you use words like brilliant, excellent performance, always cheerful. You know, there's always that positiveness that surrounds the person when you write the story. But when you talk about mental illness, and everybody seems to forget everything that is about this person and focus on a very negative, gloomy, kind of negative, I don't know whether to say negative is the correct word, negative, demeaning terminology when you refer to persons with mental illness. And then again, so it has a lot to do with the language. It has also a lot to do with where we place this story. You place this story as a headline for the simple reason that the editor wants to sell the newspaper or sell the news. But then again, you want to ask yourself the question, I am selling this content as the first story. How does it portray the family of that particular subject? How does it portray the individual on this particular story about mental health? So there are those questions to ask around it, because the stigma does not only go to the individual, it also goes to their friends and their family. So because of that extended and communal stigmatization and discrimination that could come because of your story, you also want to think about the placement of that story. Do you want to place it on page one? Do you want to make it the headline story? Or do you want to just put it as one of the other stories? It's a big issue, yes, we need to highlight it, but think about it. You want to interrogate, where are you placing this story? Is that the place where it will get the best attention with the objective that you want? Joanne, you're shaking your head like you want to say something.
No, I'm just listening to you and agreeing.
Yeah, okay. Are there any other questions, comments, observations?
Christian, I didn't
Yes, go
get the
ahead,
support of the suicide prevention. Are there any tools or support that is within the platform to some of us who are very interested about suicide prevention, on the first aid for suicide prevention? Because we're reporting a lot about the suicide, and we are not looking at the other models. Do we have models that are first aid for suicide ideation? Then suicide prevention models that are already out in the void, and journalists can actually benchmark on those to amplify them to the communities to change the narrative. Thank you.
Okay, Thank you. We'll take Catherine Gishamba and then I'll take Swala Swala next to each other. Go ahead and then we can get some comments about suicide prevention. Faith, I think if you go back to Professor's presentation, there was a slide there about suicide prevention. Okay, Catherine, go ahead.
Hi, hey, Christine.
Hi.
Hi, everyone. So I'm a journalist, trained
Yes.
journalist, and I also have lived experience. And I have to say that in Kenya, I've noticed there's change in the narrative. I feel like there's change in the way the report is done, especially on the language. However, I have a question. How does a journalist report when mentioning, how do you not mention a location, especially if it has a story behind it? So, because I, as much as I am a mental health champion and I can get easily triggered, I also have to, I also know as a journalist, you need to bring out the story for people to understand. So how do you not mention the location and still give your story?
Okay, thank you. Swala, go ahead. Swala, your microphone is mute, so you need to activate your microphone. Okay,
Thank you,
that's better.
thank you. Yeah, my name is Swala from Ghana. I am a journalist with the Ghana Broadcasting Corporation. I have done quite a number of stories about people with mental health conditions, and the purpose is to help end stigma and discrimination. But most of the time, you realize that the people with mental health conditions, their concerns about stigma and discrimination, first of all, comes from their immediate family. I remember I was doing a story about one woman with mental health conditions, and her concern was that if people see me, if people saw me talking to her about her condition, the stigma in the area will go up. And it was a bit challenging trying to convince her, to let her understand that the purpose was rather to end the stigma and not to escalate it. So most of the time, in fact, with the assistance of some NGOs that are into mental health organizations, particularly like CPRI, they adopted decent language that we should use when we are reporting about people with mental health conditions. We should not use their state of health to describe them. We should not use their body disability to describe them. But we have to use words and names that will rather project their situation instead of using words that will further worsen their conditions. So what I have to say is that let us also try, if we are not already doing it, using words that do not denigrate their personality. We shouldn't call them mad people as some people do. In fact, in Ghana here, particularly in Upper West, when you are listening to radio stations and they are discussing issues about mental health, even if calls it one as a mad person, a mad woman is on the street, the presenter will say, please, the person is not a mad woman. He is a woman with mental health conditions. If you call her mad, the person can be your sister, the person can be your auntie, your mother. So why should you describe the person as mad person? Yeah. So let's adopt words that will not further worsen their plight, but words that will project them and see and encourage them to live a normal life just like any of us. Thank you.
Okay. Thank you, Swallow. I want to read a chat that was coming from Violet Nabatanzi in Uganda. She says some issues which should be considered while reporting on mental health should include emphasizing that mental illness is real, but is common and treatable. The media should also offer hope to persons with mental disorders and should highlight stories about successful management of mental health. I'm hoping that Andrew is taking down notes. Successful management of mental illness by interviewing recovered patients, careers, and healthcare workers. In addition, we should write stories highlighting the importance of seeking care when someone has a problem of mental illness. I want to add here that probably it's high time that members of the fourth estate, journalists, need to begin to highlight to the audiences some of the symptoms of mental illness before it presents directly. There was a question about how does a journalist report without a location? I would want to propose that when you describe a location, don't describe it to the actual, GPRS, like the actual spot where this happened. You could describe the whole, the bigger location. For example, if it is a province, you can say in such and such province, or south of such and such province, north of such and such province. Make reference as opposed to actually naming the location. The reason is, it's easy for people to begin to find out, because of curiosity, to start to find out, oh, so it was in such a village. So which family was it? As opposed to if you just give it a location, a general location, like a district, a sub location, a sub county, a sub province, so that it is a bit hard for you to identify. So which particular village was it? That way, then you are protecting the person and the family as well. I know those 5 W's and H are very difficult, and the editors will put you to task to actually put them out because they want to know, where did this happen? How did it happen? I'm surprised you didn't ask, what do you do with information that you have about how the person died by suicide? And again, I want to just share and say that when you describe the how, someone else picks it up and goes to perfect the action. Deborah, can we hear from you really quick, like just a few seconds? And
Yes,
then
no,
we need to close
absolutely.
in the next 3 minutes.
Yeah, no, that's fine. First off, thank you so much for an amazing, just again, the panelists were amazing. I just wanted to quickly comment, because as a global mental health professional, specifically also working in Africa and other resource constrained settings, something that I've realized when we talk about mental health is that there tends to be this sort of outcome focus on what the end results are. So for example, we know in a lot of, for example, African countries, I'm Nigerian myself, there isn't much attention to mental health. So typically we want to report on things that we feel are emotionally charged. Suicide is one of that, right? These are things that we find jarring, whether it's on a religious level or political level, whatever that may be. But I think it's also important that we start to, as journalists, draw attention to the fact that mental health does not exist in a silo, right? They did not fall into that trap of having to romanticize, this issue around suicide. Yes, that's important, but understand that if you had to really think about it, right, that may be about maybe say 10% when we think about the issue of mental health on a larger scale. That's only a portion of that. There's so much more that happens around mental health and how it relates to culture, the economy, the development, like, women and girls, human rights. There's so much intersections there that we have to be very careful that we're also highlighting, right? So it's about speaking about mental health. Yes, we have these reports by the WHO and other organizations, but understanding when we speak about language, it's down to the language of the people in the country. So having these big reports guide how we report on mental health, but understanding how do the people in Ghana, in Nigeria, in Kenya, and Uganda, how do they define mental health? How do they define support? How do they define recovery? And being able to use that language, because there has to be ownership there. But that's just, I want to just throw that in. It's just being very mindful of that as well.
Thank you, Deborah. That was very insightful. I want to close this because we need to go and get other stuff done. And I want to look for Professor Graham. Professor Graham, could you make just few observations, some few remarks before we close? And then I'll come to Sarah.
Okay, thanks very much,
Professor
Christina.
Graham.
Just a couple of brief points.
Yes.
So this isn't talking about others or them or a minority. A quarter of us this year have mental health problems. Half of us will know somebody in our family in our lifetimes with these conditions. So it's all of us. And these are human stories. Every episode of a mental health condition is a human story. And as journalists, I think you're really interested in stories of challenge, sometimes stories of crisis, stories of support, stories of recovery. And one way into the stories is by going to NGOs, mental health organizations, both for stories and people who are trained as speakers panels, but also as, if you like, advisors, maybe sensitivity advisors about what language, what terms, how to go about, how to maintain a strict process about confidentiality, respecting the material and the sources. Just a few sources from me. And thank you for so many really, really insightful questions and comments today.
Thank you very much. Is Mark still on? Mark?
No, Christina, he had to go, but we.
Okay, so then Sarah, you're on. You can give us some few remarks.
Just to say thank you on behalf of United for Global Mental Health, particularly to Faith who organised this, and Christine for chairing it. And thank you to everyone who shared their experiences. Everyone who shared their email in the chat, we will try and come back to you with more information. But we're really grateful. We're all grateful for what you're doing in terms of reporting on mental health, and here to support you. And thank you very, very much for your work. Thank you.
Thank you, Sarah. Faith, maybe from the